Good afternoon, ladies and gentlemen. It's my pleasure to join this wonderful symposium, and also it's my great honor to be able to have such an opportunity to host this interactive session with Professor Seo. Okay, I would like to begin by introducing two cases. The first case is a 41 years old gentleman whose chief complaint was dyspnea. As you can see, his echocardiograph shows global hypokinesia with basal to mid-anteroceptal akinesia and thinning. And this is the second case, who is a 49 years old woman presenting with syncope. And her echocardiograph shows normal RV cavity size and systolic function, but enlarged RV and depressed RV systolic function was noted. These are classic echocardiographic findings for cardiac sarcoidosis, CS, and arrhythmogenic right ventricular cardiomyopathy, ARVC, which can be used to differentiate from each other. Reasonable motion abnormality in non-coronary distribution, a predilection for the interventricular basal septum, is a characteristic feature for cardiac sarcoidosis. On the other hand, regional RV akinesia or dyskinesia or aneurysm with a predilection for RVOT, RV apex, in addition to RV, can be a pathologic or imaging feature for ARVC. But it is sometimes very difficult to differentiate from each other. This is the first case, as we have seen, and as you can see here, there is RV free or bulging, which may mimic ARVC. It is not surprising because cardiac sarcoidosis can be characterized by myocardial inflammation and fibrosis with random distribution. This gross pathologic image clearly shows that scattered white area in the myocardium in a seemingly random distribution, which represent scar tissue, which is typical for cardiac sarcoidosis. So there are diverse features and presentation of cardiac sarcoidosis, such as intraventricular septal involvement of sarcoidosis, or multifocal myocardial involvement of sarcoidosis, or predominantly scar changes, or only aneurysmal changes. So I would like to hand over to Professor Seo. Could you please explain the pathologic findings of cardiac sarcoidosis?
Thank you. Thank you. Thank you for the interesting picture that was taken when we have a small group lecture for students. So the cardiac sarcoidosis is a really diverse disease, and even it has very different features depending on their viewpoint. In this heart specimen, after transplantation, you can clearly recognize multifocal fibrotic lesions in the left ventricular wall and septum and anterior wall and right ventricle. So by recognizing this kind of patch, relatively big-sized patch distribution of fibrosis, we think it could be, and it has to be, yes, and it's more likely to be sarcoidosis. But if you examine microscopically in transplanted heart, it's really difficult to recognize any granuloma in these cases because they have been treated so long time. So every sarcoidotic granuloma has disappeared already, and remaining fibrous scar is the only clue for them. So I have studied several cases of the sarcoidosis, and many of them are diagnosed already before, a long time before transplantation, so I could follow up their progress of granulomatous lesion detected from the right ventricular endomyocardial biopsy. So at that time, there was granuloma in the past, but now, after transplantation, almost absent. That is a characteristic features of sarcoidosis. But as you can recognize, it is relatively clear that the macroscopic distribution of scar is a characteristic feature. And also, in the right ventricular wall, the involvement of sarcoidosis makes right ventricular thinning and replacement of fatty tissue. So in some sense, if you look at close up this area, we may say this can be a kind of arrhythmogenic right ventricular cardiomyopathy. But in this case, I think it's not. There are fatty replacement, but more predominantly it's a fibrotic lesion. So I'd prefer this as a sarcoidosis, in addition to the previous biopsy with granuloma in the endomyocardial biopsy. So let's return the microscope to Professor Park.
Thank you for your explanation. As explained by Professor Seoul, certain features of myocardial environment in more than 90% of cases is RV free wall environment, in addition to LV subepicardial or LV multifocal or septal environment. So this is a cardiac MR image of the case number 1, showing the akinesia of mid to apical free wall of the RV, which is corresponding to the pathology finding explained by Professor Seoul. And also delayed enhancement in the RV was noted in these MR images, suggesting the presence of fibrosis, which is also corresponding to the pathology findings. This is a cardiac MR image of case number 2. As you can see here, RV dilatation with RV free wall outpouching is noted. So, and we know that the one representative finding of ARVC is the fat infiltration of the RV free wall. So I have one question to Professor Seoul. Could you explain the pathology finding of ARVC, especially, and what's your opinion on whether the fat infiltration of RV can be unique pathology feature for ARVC or not?
Thank you very much. Let me show a hot specimen for ARVC. These specimens are kindly presented from the Samsung Medical Center, and they have 2 beautiful cases of heart transplantation due to ARVC. In this heart specimen, we can recognize a great big size of right ventricle with very enormous thickening of right ventricular wall and almost a wall, completely absence of a myocardial layer in the multifocal area, and some of the remaining myocardium is sometimes paper thin like this. And also involvement of left ventricle by ARVC is shown in this area. And so I think it's macroscopically very characteristic of arrhythmogenic right ventricular cardiomyopathy. But fatty tissue is not specific for ARVC, but in this case, it is the macroscopic and enormous replacement and fatty growth, overgrowth of myocardium in the right ventricle, mainly in the right ventricle, and some on the left ventricle is a key feature of ARVC. Another case also show similar features. This case, the right ventricle is not very much dilated, but replacement of fatty tissue is very much significant in this case also. So the key feature of ARVC is not is replacement of right ventricle by fatty tissue, but it is macroscopic, not microscopic. So we may see some microscopic fatty replacement in infiltration in right ventricular endomyocardial biopsy, but it doesn't make any suggestion of ARVC in my sense. So if you biopsy this sample, we can also see the fatty tissue in RV biopsy, but still we can make diagnosis of ARVC after recognizing this whole growth level or macroscopic significant replacement of right ventricle by fatty tissue. So there are a certain gap of understanding and definition of ARVC and sarcoidosis. But in my opinion, we can say the ARVC is a very much thickening of normal thickening of fibrous tissue, but sarcoidosis is a rather different disease. Fatty growth may be secondary to the replacement of fibrous myocardium by fibrous scar. But also, as you can compare here, these two specimens together, there are certain features showing in both disease that fatty overgrowth is present both this sarcoidosis and also, but the level and degree of fatty overgrowth is much more severe in ARVC. So that's my understanding. And also, importantly, we can make different disease process. The sarcoidosis is a progressive granulomatous inflammation, can be detected by endomyocardial biopsy. But sensitivity of endomyocardial biopsy for diagnosing sarcoidosis is very low, because it's not really always possible to find sarcoidosis granuloma, because that distribution of granuloma is not the global or general, but it's only limited to certain place of myocardium. Now, that's the problem. And ARVC, I think it can be based on the more macroscopic and clinical level of this lesion rather than very tiny specimen of endomyocardial biopsy specimen. And could you wrap up?
Okay. So as explained by Professor Seoul, fatty changes are more extensive and prominent in ARVC than cardiac psychosis, but we cannot say that fatty changes is, we can say that fatty change is not the unique pathologic feature of ARVC. This is a paper published by Professor Seoul, wonderfully summarizing the indirect pathology indicators for cardiac psychosis, not ARVC. As shown here, there are different types of fatty changes in endomyocardial biopsies obtained from cardiac psychosis patient. And this is one example. This is a transplant heart diagnosed with psychosis and hypertrophied ventricle. You can see the multifocal confirmed fibrosis here and here, but there are prominent epicardial fatty tissue involving RV. So how can we differentiate between cardiac psychosis and ARVC? So some findings more suggestive for cardiac psychosis than ARVC are like this. Older age or symptom onset. One study showed that the mean age for symptom development is 45 years for cardiac psychosis, but 23 years for ARVC. And non-familial pattern of disease, and PR interval prolongation, high-grade AV block, interventricular conduction disturbance due to predominantly interventricular septal involvement. And also myocardial delayed enhancement of involving the septum is a feature finding for cardiac psychosis. And we can also take a hint from mediastinal lymphadenopathy because cardiac psychosis is a systemic disease. On the other hand, other findings more suggestive for ARVC than cardiac psychosis is younger age of symptom onset and familial pattern of disease because the ARVC is has a genetic background, such as mutations in desmosome-related genes. And as discussed before, intramyocardial fat can be, it's not the unique feature, but it can give a hint for us to differentiate from ARVC from cardiac sarcoidosis. So to distinguish from each other, we should consider the clinical characteristics, including age and family history, and this finding. For example, conduction disturbance can be more favorable for cardiac sarcoidosis, and imaging finding also give a clue, such as predilection for L receptor environment. And other findings can be mediastinal lymphadenopathy, suggestive of cardiac sarcoidosis, and intramyocardial fat, more suggestive of ARVC than cardiac sarcoidosis. Thank you for your attention.